so we're going to get started. I believe in one of your first chapters here, we're going to go over some of the pregnancy categories. Is that something you guys have covered? Yes. Okay, so they have been replaced. You won't really see them much except for in your OB, possibly. But you have pregnancy A, category A, that has very little side effects or no risk at all when you're giving them to someone who is pregnant. And then you have B, which they do not have enough studies for, but within animal research, they have shown that they should be safe. So you'll see that used still. You then also have pregnancy category C, which you again do not have enough human studies done. But they have shown some problems with animals, so you will very rarely, if ever, see those used within humans. And then in pregnancy category D, they've done some human studies, and the drug has been shown to have fetal risks there. And then in pregnancy category X, you will not use at all in humans. They have definitely been shown to negatively impact the fetus. So when we're looking at this, we're going to really think about teaching for heterogeneity. Sorry, I can never pronounce that word. So you're going to advise women that the medication can have effect on the baby, and when giving it, you're going to think about that risk versus the benefit. So let's say like a woman got in a car accident and they had to give a medication that would possibly injure the baby. If it's saving the mother's life, they might choose to give that medication, even though it could possibly harm the infant or fetus. And so you're always going to advise a woman to check with their doctor prior to giving them the new medication. Okay, so with pharmacokinetics, you have neonatal and pediatric ones. So that's going to be your absorption. Is the gastric pH is less in 1 to 2 year olds, and you also have a slowed gastric emptying. And because of this, we have an immature liver in them, and you'll have a lower first pass elimination. With infants, you will also give intramuscularly, is absorbed faster, but it can also be irregular absorption. Okay. Can you explain first pass? So first pass is for infants. So with first pass in infants, it's the same to an extent as first pass effect that you would see in an adult, except for the infant does not release as much or excrete as much of the drug within the GI tract, because their GI tract is slowed down compared to an adult's GI tract. So they get more of the medication absorbed than the adults do. Does that help at all? Okay. And then when it comes to distribution in the neonatals and pediatrics, since they have an increased percent of total body water and the decreased fat content, you're gonna have, they will also have like a decreased protein binding. So you have more drugs that enter the brain, but it can also affect how the drug is carried throughout the body. Okay. So when it comes to metabolism, they do not have enough microsomal enzymes. And so older children may have a higher metabolism that require higher doses than infants because they have more of those enzymes there. And with excretion, kidney immaturity affects the GFR and the tubular secretion of it. So you have that decreased perfusion rate of the kidneys and a reduced excretion rate of the drug. So it stays in their system longer and at higher concentrations than adolescents and adults. Okay, so for pediatric dosing calculations, you'll most commonly see it as either the body surface area. So you'll have like micrograms per kilogram per day or micrograms per kilogram per minute. They do a lot with body weight and centimeters. So the factors affecting pediatric drug dosages, you're going to have thinner skin so that it's going to be more permeable. And with the lower stomach acid pH, you're going to not be able to kill bacteria as well in pediatrics. The lungs in children are also have a weaker mucosal barrier, so it's easier for bacteria to pass through there. And then you have an unregulated body temp, so they dehydrate very quickly. And then when it comes to impaired drug metabolism and secretion, that is due to their immature liver and kidneys.
Okay, so one thing actually about this slide in the bottom corner where there's that chart, this is how you calculate their body surface area. So you're using their height, and usually you're going to use centimeters because everything's metric in healthcare. So you're going to get to their height, and then you're going to get to their weight, and you're going to connect them like a line. And wherever that line meets up on the middle kind of ruler, that's what their body surface area is.
Okay. Okay, so in older adults, when it comes to absorption, you have a less acidic gastric pH, and you also, again, have that slow gastric emptying. But with adults, it's a little different because you now have a reduced blood flow to the GI tract, which decreases the the surface area that they can absorb the medications in. And then with distribution, they're the opposite of pediatrics, and they have a low total body fat or body water percentage and an increased fat percentage. They also have that decreased protein production, so you have low binding when it comes to the drugs there, and you'll have that increased circulation of the free drug. And then for metabolism, you're going to have a decreased microsomal enzyme affecting the metabolism again, and you will also have that decreased blood flow to the liver, so it can take longer for the drugs to metabolize in the system. And with excretion, you'll have that decreased excretion from the GFR being decreased and the number of nephrons. You will also have a less effective drug clearance. Okay, so how drugs are approved. You have 5 stages. You have the, okay, so would medication dosage be lower for older adults? Yes, medication dosages are lower for older adults depending on what the medication is and how it's metabolized by the body. But generally they are lower. Okay, so you have 5 steps for a drug to be approved. You're going to start with those preclinical trials, and that is where chemical tests are only done on the laboratory animals. Once you get to your phase 1 study, they'll be tested on human volunteers. In phase 2, a drug is tried on informed patients that would have that condition that it's being used for. In phase 3, the drug has been brought out onto the clinical market and is now available for prescription use. And in phase 4 is once a drug has been released and they are continuing to evaluate it and make sure that they have enough information on side effects and all of that. Okay. You also have controlled substances that are listed under different schedules. And so your schedule 5 is going to be a medication that has the least potential possibility for abuse among the controlled substance group. So that would be like your Robitussin, your codeine. And then schedule 4, where you have an abuse potential that's going to be less than a schedule 3 drug, but still higher than that schedule 5 drug. And so that is like various benzodiazepines and sibutramine. So if you want to think about your like lorazepam, your Ativan, that would be a schedule 4 drug. Schedule 3 is going to be a less potential for abuse there when compared to schedule 1 or 2, but you still have that higher chance when comparing it to a schedule 4 medication, and it can lead to a moderate or low dependence or a high psychological dependence on that medication. So it would be any products that are within less than 90 milligrams of codeine per dosage on the unit. So that'd be like Tylenol 3 or your Tylenol and codeine, along with some anabolic steroids and ketamine. In schedule 2, you have that high abuse potential with those severe psychological and physical dependence, but the medications have an accepted medical use and so are prescribed and dispensed or administered by medical professionals. So that's going to be your morphine, your codeine, Norco, methadone, oxycodone, fentanyl, the typical narcotics you would see given in medical surgical units. And for schedule 1, there is no acceptable medical use in the medical community for them. They have a very high abuse potential, and they cannot be prescribed, dispensed, or administered for any medical use. So that's your heroin, ecstasy, LSD. Does anyone have any questions on that? Okay.
Also, just to go along with that, kind of what she's saying is like if you go from schedule 1 to 5, 5 is your least likely and 1 is your most likely in terms of abuse potential. So specifically for pharmacology and the exams that you guys are taking, make sure that you remember that schedule 1 drugs are not medications that you are going to see or, mess around with in the medical field. Those are strictly illegal medications.
Thank you, Jenna. Okay, so the next thing we have is our black box warnings. So these are required by the FDA, and they are put on drugs that have serious safety risks. They're meant to warn about dangerous side effects. So an example would be what you see in this box here, where it says, do not drink alcoholic beverages when taking this medication, except for it would say something along the lines of, this medication can cause osteoporosis. So you'll see them on the medication box itself. Okay, so some key terms we have for you are addiction. That's going to be the neuropsychological disorder or persistent urge to engage in a behavior or the abuse of medication. Tolerance is when your body gets used to the drug and now requires a higher dose to get the desired effect. And dependence is the physical or psychological symptoms related to the body depending on a drug. So you would see dependence become a thing when you have withdrawals occurring from not taking opioids as consistently as someone had been taking them.
Okay, so for opioids, there are a couple of different ones. I think the ones that you guys are going to be seeing the most is like hydrocodone, morphine, and oxycodone. Codeine is one that we usually mix with like cough syrups. I think those are Schedule 4. So for your action for these specifically act at opioid receptor sites in the nervous system, and they produce like sedation, kind of get rid of pain. That's why their indication is relieve severe pain. Sometimes we do use opioids though with general anesthesia as well. Some of the side effects that are common are orthohypotension, respiratory depression, nausea, vomiting, dizziness, anxiety, and hallucinations. So the reversal agent for opioids is Narcan. I'm sure you guys have all heard of it. So there's a couple of different forms for opioids. Pretty much every form you can do by mouth, and that one's going to take 15 to 30 minutes. IV is 2 to 5, IM 15 to 60, and sub-Q is 15 to 30. You're most commonly going to see PO and IV. And I'm pretty sure that you guys need to know that for your exam. Analgesic is when you are switching from one medication to another, so one opioid to a different opioid, and you're trying to get the same therapeutic effect. So like we have right here, oral hydromorphone is equivalent to oral morphine in a 1-to-4 ratio. So that's how you'd be calculating that if you were in a setting where you needed to switch someone to a different opioid. Same thing with the parenteral hydromorphone and morphine, 1-to-20. Contraindications for opioids is really things that are going to affect their respiratory system. So severe asthma, sometimes people with COPD, any type of, respiratory irregularities, maybe they're not able to breathe sufficiently, you're going to be very careful with those patients. You're also going to be really careful with your patients that have an increased ICP. So that could be patients if they came in from a car accident, their ICP could be higher. So physical dependence is when your body is physically dependent on it, like your body doesn't know how to function without that medication. So if someone takes, let's say, like if somebody were to take hydrocodone all the time, your body is going to get so used to always having that available that it won't know how to kind of function if it doesn't have it. So your body almost malfunctions. Whereas in the psychological dependence way, that's kind of just, your brain telling you, hey, I really need that. Right.
So to add on there with the psychological, it is having that obsessive desire to feel the euphoric effects or the high that the medication gives.
I guess you could also put it if like psychological versus physical is more of like a want versus need,
Yep.
if that makes sense. Um,
And with a physical dependence, you're trying to not have those withdrawal symptoms. So not having those tremors and headache, the stuff that you would feel if you're not taking the medication.
so we're gonna use caution with opioids, especially with pregnancy. I'm not sure if they actually prescribe opioids during pregnancy. But adverse effects are pretty common adverse effects from many medications: nausea, vomiting, CNS depression, constipation, and urinary retention, which urinary retention can actually be very, that can be very serious because it can cause a lot of other problems as well that you guys are going to learn about when you're in your med surg class. So for opioid and antagonists, these are drugs that bind to opioid receptors, but they don't activate the receptor. So it kind of reverses the effect of an opioid. That's why naloxone is our reversal agent. That's what you're going to use if you're noticing respiratory depression in your patients. Side effects are increased heart rate. Sometimes, so it actually affects people differently. Sometimes it can lower their blood pressure, or sometimes it can make it go really high. And that's why you have dysrhythmias as well, because it affects the whole cardiac system. So with agonist antagonists, these are ones that act at opioid receptor sites to produce analgesia. And this one is, these ones are used more so with your general anesthesia than just on their own. Same kind of side effects: lightheadedness, dizziness, sedation, euphoria. This one, though, you can actually, there's more palpitations than with regular opioids, but they both have a pretty high level of physical dependence. So just for some nursing considerations, make sure that you're, assessing your patient for the possibility of an opioid dependency. You're also going to want to check to see if they, do they have a history of narcotic abuse? Do you have naloxone available? Because if you don't have Narcan available, you probably shouldn't be giving an opioid, because then you have no way of saving that patient if for some reason something happened. Same thing right here. You're going to contact the physician and withhold doses if you're seeing any declines, abnormal vital signs, or a low respiratory rate, because that means that we're getting close to respiratory arrest. Orthostatic hypotension, that was one of the side effects that I talked about earlier. That means that they're going to be a fall risk. So they're going to be, there's with orthostatic hypotension, when they stand up, their blood pressure is going to drop and they could actually pass out. So you're going to want to make sure that as well you're really keeping up on your safety with the patient. So make sure that your bed rails are up, the call light is within reach, use your bed alarm, use all that kind of stuff, because you really want to make sure that they're not getting up while they're on opioids. It is also important to make sure that you're doing your I's and O's. Again, that's for that retention. And there's a couple more on there. So
this
yeah.
is being recorded. Once we have the recording done, we'll send it to Anne Marie and your instructors, and they should be able to post it onto the Blackboard pages for you.
So a couple of kind of key terms. Opioid abstinence syndrome. So that's, exactly what it sounds like. That's kind of your withdrawals. So you're going to have anxiety, irritability, chills, pain. They're going to have a runny nose. They're going to be sweaty, nauseous, vomiting, abdominal cramps, diarrhea. Breakthrough pain is when you have like someone who's been using narcotics for a really long time. They might have to get their baseline narcotic dose kind of titrated up to decrease that breakthrough pain. Because again, breakthrough pain is the same. It kind of correlates with not dependence.
Tolerance.
Yes. Thank you.
Yeah. So also with breakthrough pain, if you're giving a oral narcotic, so say someone came back from surgery or they're in a sickle cell crisis and you're giving an oral narcotic like Norco, breakthrough pain might be treated with an IV narcotic like Dilaudid in that case.
Mm-hmm. That's another, so too, that's why you need to know what your onsets are for the different routes of these medications, because for breakthrough pain, you're not going to want to give someone, an IM that's going to take 15 minutes to 60 minutes. You're going to want something that's fast. So acetaminophen, I think we all know what that is. It's used for mild to moderate pain. More commonly in the hospital, it's used for fever. Just make sure that your patient doesn't have a drug allergy. Check their liver level or their liver labs. It's also contraindicated for a G6PD deficiency. So these are a couple of terms that have to do with general and local anesthetic. So malignant hyperthermia is basically when a patient's body temperature goes over 104 degrees. This is really dangerous. It's actually, it's an emergency, and a lot of people who end up with malignant hyperthermia die because of it. So you're really looking for these top three, which is muscle rigidity, tachypnea, and tachycardia. They're going to be sweating too, but that's because of the fact that their body temperature is so high. You're going to try and do cooling measures to get them to cool down with that one. Oops. So with balanced anesthesia, this is where you're using a combination of multiple types of drugs to get a smooth effect. It makes sure that you have a smooth and rapid induction, and it makes sure that the patient is as relaxed as possible. And this can be done with emetics, so like that's like your Zofran, antihistamines, which is your Benadryl, opioids, sedatives, and then any type of pre-op medications that they might give the patient. Sometimes pre-op medications could include like something for anxiety. So conscious sedation, there's no loss of consciousness. You're really decreasing anxiety and pain sensitivity. And they're not going to remember this procedure. So this is done a lot in the emergency room when somebody comes in with a dislocation. So I had a patient once, he came in and he actually had like broken his wrist, but his elbow was out of the socket and they had to reset it. So they put him under conscious sedation, which is it's an IV kind of. They get kind of loopy, they get funny. And then you do what you have to do. They will still react, which can be scary if you're not aware of that. They are still gonna, ow, that hurt or whatever. They're gonna react to it, but afterwards, when those medications wear off, they're not gonna remember a thing. They're not gonna know that you reset their arm or, whatever. This one is a lot better. than other types of anesthesia, specifically because there's less risk for respiratory arrest. So with local anesthesia, that's where we're using kind of like lidocaine, numbing an area. Um, Adverse effects, you can lose skin integrity, respiratory suppression, slow heart rate, hypotension. You can get what's called a spinal headache, which usually you would just use, some rest to get rid of. Do you guys know what a spinal headache is?
No.
Okay. It is not increased ICP. So sometimes when I don't even know how to completely explain it, but sometimes when you, especially like, so spinal headaches are really common when you're doing anesthesia with like spinal blocks. When you're doing something that involves the spinal cord, there is a chance that you could create kind of like an air pocket in there where the fluid is supposed to be. And that can cause a lot of symptoms for these people that have it. A lot of headaches, very painful, nausea, vomiting. Usually it will go away with just rest and time, but for some people, they actually have to get blood, their own blood, injected into that space to fill it. And then directly after that, they feel completely fine and it goes away. It's not very common. You most likely will not see it, but it is something that happens. For our general anesthesia adverse effects, we already kind of talked about malignant hyperthermia. So there's also toxicity. You could accidentally overdose on it. And obviously it could cause cardiac and respiratory arrest. You want to make sure that when you're using any type of anesthesia, that you have emergency equipment to maintain an airway. Always remember your ABCs as well. And then again, just really watch for those signs and symptoms of malignant hyperthermia. That one's really important. So with your neuromuscular junction blocking agents, these are your ones that you're using to kind of paralyze someone. These are usually used when somebody is being put on a vent. Actually, when you use these agents on people, it paralyzes everything. It paralyzes the muscles that control their lungs and everything. So they cannot breathe on their own. They cannot do anything on their own. So that's why when you're using this with patients, you really have to make sure that, you're providing them that airway. Some of adverse effects of these is, prolonged paralysis, respiratory depression. Again, that's really common with any type of drug that's kind of in this class. Apnea, hypotension, arrhythmias, and hyperkalemia. Your assessments are super, super vital when you are using these agents with your patients. You want to make sure you're watching your vital signs. Watch for that rise in body temperature because it's really common with this one too to see that malignant hyperthermia. You want to get your baseline labs just so you can make sure that while you're using these agents, nothing's drastically changing. You want to get an ECG, again, just covering your bases. Check what their oxygen saturation is. Make sure they're getting enough oxygen since they can't breathe on their own. And again, just remember your ABCs.
So also with those neuro blocking agents, you are never going to give that agent first. You will always give a sedative first because as soon as you give that agent, their mind is still thinking and they'll want to say something, but they physically can't. So it's very traumatizing if you're giving a neuromuscular junction blocking agent without having given a sedative first.
Yes, thank you, Abby. That's actually very, very important. I would remember that if I were you. So it's CNS depressants. Those are the benzodiazepines. It's a sedative, depresses the CNS. We use it mostly for sedation or sleep induction. You also are going to use this with your CWA patients in the hospital. So anyone that you have that's going through alcohol withdrawals, probably going to give them a benzodiazepine to try and get them to chill out. It's contraindicated for people with narrow angle glaucoma and in pregnancy, drowsiness, sedation, cognitive impairment. Again, they're going to be a fall hazard because of that cognitive impairment. They're not going to know what they can and can't do. So you're really going to make sure that you have those fall precautions with these people. It can also cause daytime sleepiness, kind of like a sleep hangover. And then for patient teaching, you have to make sure that they do not drink any grapefruit juice. They cannot take it with macrolide antibiotics, and then no CNS depressants. This one's very, very important that they do not mix alcohol or other opioids with these benzodiazepines. And then the reversal agent is flumazenil.
So with benzodiazepines and alcohol withdrawals, you'll probably most commonly see lorazepam or Ativan used in these patients. And it's all based off of a score.
So for barbiturates and not barbiturate-like drugs, we use these for anesthesia, to reduce ICP, prophylaxis for epileptic seizures, and to really control those convulsions. So this is your drug of choice for status epilepticus. I know if you're in Amy's class, this is on your study guide. Your adverse effects are, again, CNS depression, physical dependency, and respiratory depression. Make sure that you're watching for that CNS depression. Take caution with your older adults. Again, like we learned earlier with the absorption and all of that stuff, their body is going to be affected much differently than someone our age by these medications. So it could be a stronger effect on them with more side effects. You're going to watch your serum levels. So make sure that you're monitoring your CBC, BUN, creatinine, and electrolytes. And then your therapeutic level, it's pretty small range. It's 10 to 40 micrograms per ml. So then hypnotics, you want to give these 30 to 60 minutes prior to bedtime. Make sure that you're monitoring vital signs and assessing their level of consciousness. This is another one where, safety is important. They're going to be a fall risk because they are going to be a little bit impaired. Again, no alcohol, no smoking with these. And then adverse effects are ataxia, which is impaired coordination, dizziness, asthenia, which is weakness, and somnolence, which is like being tired and fatigued. So, actually, Abby, do you want to do this one?
Yep, I can. So for muscle relaxants, the main ones you're going to be seeing used are those centrally acting muscle relaxants. So that's your baclofen, your cyclobenzaprine, or Flexeril. And they have two different indications. So you have the indication, which is a muscle spasm, and that's like a musculoskeletal injury, like a cramping to your muscle type. And then you have your muscle spasticity, which would be damage to the central nervous system and not having control over that muscle. Some contraindications of these are having a known allergy and then rheumatoid arthritis. And then when it comes to adverse effects, they're going to have CNS depression. Can anyone tell me what some signs of CNS depression are? Balance, yep. Low respiratory rate. Yep. Sedation. Not so much low BP as a result of CNS depression, but that can be a adverse effect for this medication. So it's going to be those changes to level of consciousness that you're going to be looking for. You can also have dry mouth, Yes, lethargy is one of those too. So can anyone tell me what happens with the use of these, or what can happen with the use of these in the elderly population? Respiratory depression? Not quite. So kind of specifically to muscle relaxants and centrally acting muscle relaxants, in the elderly population, you can see confusion as a result of using these. So that is something you definitely want to look for. Yes. And then when it comes to patient safety, you want to educate people to not use like heavy machinery or drive while using these until they know how it affects them personally. Because just because someone is able to take baclofen and drive doesn't mean the next person would be able to do that. It can cause a lot of fatigue. Okay. And then for CNS stimulants, you have, I believe Miss Amy's class for sure has migraine medications. I'm not sure about Dr. Servanen's. But your most common is going to be the triptans. So like a sumatriptan, rizatriptan. And what they do is they vasoconstrict those cranial vessels by binding to the selective serotonin receptors in the body or brain there. And you're going to only use these in acute migraine attacks. They're not for preventative measures when it comes to migraines. And you'll take it on the first symptom of your migraine. Some contraindications are pregnancy, having a known allergy to the medication, and coronary artery disease, because you would not want to be stressing your veins in that case, or arteries. So some adverse effects for these is like a chest pressure. It's like a heavy feeling in your chest if you're taking this. It's expected. You also can feel some numbness and tingling, have some weakness, and it can cause blood pressure alterations. And when you're having nursing considerations for someone taking a triptan, you're going to look for pain level before you give this medication, and you're also going to reassess. And reassessing is very important with this, because if after an hour there's no relief, they're able to give a second dose. And then you also want to make sure to check for any adverse effects or side effects from the medication. And before giving, you want to make sure that they are not using CNS depressants or alcohol. Okay, for CNS stimulants, we have methylphenidate, I can never say that, and dextromethapine. So that's Ritalin is the methylphenidate, and these are indicated for ADHD, ADD, narcolepsy. And the pharmacokinetics is something that I believe Miss Reeves' class has. And that's going to be, it's a rapid absorption within the GI tract. It's metabolized by the liver and it will be excreted in the urine. This peaks at 2 to 4 hours after the medication has been given. And some contraindications is if you have marked anxiety, agitation, tension, or have cardiac structural abnormalities. For nursing implications, especially in children, you want to monitor growth, because it can like stop their growth. So it's very important that you monitor height and weight. So mechanism of action is how it works within the body itself, like what receptors it works on or the effect it has on the actual anatomy of the body. Whereas pharmacokinetics is how it's used by the body. So that's going to be like your absorption, your distribution, okay? You also want to monitor for sleep and wake cycles. You do not want to be giving this medication before someone's going to go to sleep. They recommend at least 4 to 6 hours before sleeping is that last dose. You're going to monitor vital signs. These medications can cause tachycardia and increase in blood pressure. And you're also going to monitor the effectiveness because you can build a tolerance to these medications. And some of the medications aren't right, and so you have to try a different one.
So with these medications, methylphenidate and dextroamphetamine, these are your typical stimulant medications, like Abby said, for ADHD. So this is your Adderall, Vyvanse, Concerta, all of those medications. A lot of people get put on them, and when they're young, to treat ADHD, they're actually not very good for you. Going back to the contraindication where it talks about cardiac structural abnormalities. Oh my goodness. These stimulants are going to cause your cardiac system to kind of work in overdrive. You're going to see higher heart rates, sometimes higher blood pressure. It is not good to be on stimulant medications for a very long time. You also cannot take stimulant medications while you are pregnant. And then going back to the contraindications, so not so much as a contraindication, but as like a side effect with Adderall, you might sometimes hear people refer to it as Matterall because the biggest side effect of Adderall medication is agitation and, just feeling mad all the time. But it is really important that you are not giving it too close to bedtime. That's usually these medications are taken in the morning when you wake up, and then sometimes people get a booster med in the afternoon, which is usually a smaller dose, and that's usually given between 1 and 3 p.m. They don't want you to go any later than that because then you might not be able to sleep.
Okay, so anti-Parkinson drugs. Your main anti-Parkinson drug is going to be those dopamine agonists. That's levodopa, carbidopa. So levodopa is going to increase that dopamine level. It's directly stimulating the dopamine receptors in that substantia nigra area and restoring balance to the body there to help relieve those symptoms of Parkinson's, so the slow shuffle and gait, tremors, aphasias. With levodopa, that is the precursor to dopamine, and until it crosses over into the blood-brain barrier where it's converted into dopamine inside the brain. So you have to combine levodopa with carbidopa. Carbidopa reduces your GI metabolism of levodopa so that less levodopa is needed to treat the side effects, or to treat and side effects are less severe. Carbidopa also helps use a smaller amount of levodopa to cross that blood-brain barrier. And then when it comes to anticholinergics, that is going to be, I'm sorry, I just lost the page for it. So they'll use anticholinergics along with levodopa and carbidopa in order to control some of the other side effects. So that would just be like some of the tremoring that can occur. Let me see if I can pull it up here.
Have you guys talked about anticholinergics in class yet?
Okay, so the most common anticholinergic is going to be benzotropine or your cogentin, and that blocks that parasympathetic nervous system by blocking the action of acetylcholine in the CNS to normalize that acetylcholine dopamine imbalance that's occurring. So like I said, it can help reduce or control those muscle tremors and rigidity, but it will not relieve any of the bradykinesia that occurs. And it's also absorbed in the GI tract. It'll peak in 1 to 4 hours. It is metabolized in the liver and excreted by the different cellular pathways. And then for this, anticholinergics can cross the placenta and enter the breast milk, so it would be considered something that you might not want to take while pregnant.
And then also with anticholinergics, if you need help with remembering what the side effects are, so one of the things that anticholinergics do is they kind of dry you up. So you're going to think of high and dry. So you're going to have a high heart rate, but you're going to have dry eyes, dry mouth. You're not going to be able to sweat. So they do give this to people for hyperhidrosis as well, because it'll, stop you from sweating. And then it's also going to cause overheating. So it really has a lot to do with, taking away hydration from your body, which for some cases, for using it for hyperhidrosis is a good thing. But for other cases, that can be seen as an adverse effect for some patients using these medications.
Okay. For anti-epileptic drugs, you have your Hydantoins, which are used in the treatment of tonic-clonic seizures and partial seizures, and they stabilize the nerve membranes in the CNS. And then the nursing implications with that is they are highly protein bound, so you have to keep a watch on that albumin level. You're always going to check that because it has a very thorough neurotherapeutic index at 10 to 28 micrograms per milliliter. IV administration with this is very irritating to the veins, so it would be a slow IV with a large gauge 20 plus, and you have to use a filter when you're drawing this one up and giving. So it is only compatible with normal saline. And when giving this, you are monitoring your liver and kidney functions. Some adverse effects are gingival hyperplasia, CNS depression, thrombocytopenia, and a pink or orange urine. And so, let's see. Some nursing considerations are you're going to take them at the same time with your meals, and you're not going to want to crush chew them. It can impair your driving. It's not a cure, and you will need to wear a medical alert tag. So for anti-epileptic drugs, we have benzodiazepines again. So benzodiazepines will also stabilize the central nervous system membranes and are used in convulsive seizures. The adverse effects for them, again, is drowsiness, sedation, depression, bradycardia, or tachycardia. And then you also have gabapentin, which is used to treat neuropathy and neuropathic pain in focal or partial seizures, and pregabalin, which is used for neuropathic pain post-herpetic neuralgia and fibromyalgia. Okay, so I'm not sure if both classes are covering psychotherapeutic drugs or not, but psychotherapeutic drugs, you have your antipsychotics, which that is your haloperidol, or Haldol. And when giving those drugs, you have to be very careful to watch for side effects of EPS, or that extrapyramidal syndrome, and also tardive dyskinesia. Another is going to be your anti-manic drugs. So that is most commonly given with bipolar cases, and that's going to be your lithium. So you have to be careful with lithium because lithium has a also very narrow therapeutic range, and you need to keep an eye out for lithium toxicity when giving them. So, yeah. Let me see here. For antidepressants, you have your SSRIs and your SNRIs. That's your serotonin. Yeah, serotonin. Sorry, give me a second. I lost my notes.
Selective serotonin reuptake inhibitor.
Yes, and your SNRIs, your selective norepinephrine reuptake inhibitor. So that's going to be your duloxetine or your Cymbalta, and then your venlafaxine or your Effexor. And then you also have your tricyclic antidepressants, which reduce the uptake of 5-HT and norepinephrine, so serotonin and norepinephrine, into the nerves. They're all very similar, so the choice depends on the individual response to the drug and the tolerance of adverse effects when it comes to tricyclic antidepressants. They're very commonly used in obsessive compulsive disorders. And with these, you can see weight gain because it can increase your appetite, but you're not going to use this if you have a known allergy, have had a recent heart attack, and are pregnant or lactating. So with this, you will also never give someone a tricyclic antidepressant if they have just been taking an MAOI or vice versa there. So MAOIs, the monoamine oxidase inhibitors. Can anyone tell me why we don't use MAOIs anymore? So MAOIs have a lot of, yes, they cannot be mixed with other drugs. You also have to be on a very specific diet. You can't drink anything that has been, well, basically eat or drink anything that's aged. So aged cheeses, aged meats, it can cause adverse effect or adverse reactions such as a hypertensive crisis because they have tyramine in them. It can also cause dizziness, nervousness, mania, liver toxicity, nausea, vomiting, diarrhea, insomnia. It has more risks than benefits when giving an MAOI. Okay, I think that's all we have. Does anyone have any other questions?
I have a question. So
Yes.
I wanted to know, as far as the anti-seizure medications, because there's the certain type that they have for the seizures and the narcolepsy, but then there's two or three more. I'm looking for the name now, but okay. So my question was, I wanted to know the like as far as like the class.
The class for, you were kind of cutting out there.
I'm sorry, can you hear me now?
Yeah, I can hear you now.
Okay, so I was asking, as far as the Hydantoins, do those fall under the barbiturates category as far as like the drug class, or would it just be like an seizure medication as well?
That one's
So
just an anti-epileptic. I'm pretty sure.
yes, that one is just an anti-epileptic.
And then make sure that you guys know too, for each one of those anti-epileptic drugs, make sure that you know which type of seizures that they're used for. And then make sure that you know your therapeutic ranges as well, especially for your barbiturates and your Hydantoins. I don't even know how to say that one. Does anyone else have any questions? And then once we're done here, we'll send the recording over to Dr. Sarah Vannon so that she can upload that for you guys. And then if you're in Amy Reeves' class, we should be able to upload it directly. But you guys should have access to it tomorrow sometime.
Okay, I actually do have another question.
Mm-hmm.
Okay, so I know for the CNS stimulants, dextro and ketamine, and then the amphetamine, those fall under that category. But for like the automoxamine, would that just be like, would the non-amphetamine just be the class for those?
Whose class are you in?
I'm in Amy's class.
You're in Amy's. Where are you looking at the study guide when you're saying that, or when you're asking that?
No, I was actually going through my notes because in our class, she did give us the CNS stimulants, but she also touched on the non ones. I believe there was, yeah, there's like three different kind of those. So I was just trying to see like, even though it's a non-amphetamine, would it still fall like under the CNS stimulants class, or
Give me 1 second. Let me find her chapter slides and then I will explain that a little bit more.
So
okay,
it is still a
chapter
stimulant.
13.
Mm-hmm.
Yep. So it is still going to be considered a CNS stimulant. It's just not acting on the same receptors that the amphetamine stimulants do. Yes, we will post the PowerPoint.
Okay, I'm sorry. I do have one more question for you.
That's okay.
Okay, so I wanted to know, and you also know, do you have like anything regarding the categories? I'm trying to look through my notes so I can tell you like the exact chapter, but I know she mentioned something to us about some type of categories. I think it was in the chapter that was talking about the FDA for like the drugs and stuff.
Are you talking about pregnancy categories or controlled substance categories?
I'm actually not sure. I'm trying to find it now.
Because as far as I think it's chapter 3, there's the pregnancy categories, which is this little image right here. Which pretty much all you need to know for the pregnancy categories is that category X means you're not going to give it to a pregnant woman. This is the same thing as with the controlled substances, going from A down the list. A has, no side effects, no risk, and X is the most risk. We're not going to do it. I know Amy's not texting you guys on that. At least that's what it said on the study guide. And then for controlled substances, this is the other one.
Okay, you said category X is the one that you wouldn't give to the mom.
Right. And then now in 2015, they got rid of the pregnancy categories. And now they use 3 subsections. So they'll say you cannot use it if you're pregnant, you cannot use it if you are breastfeeding, or that the medication could cause potential reproductive issues for female or males. That goes right back to the black box. Like there will be a sticker sometimes, and that will literally say like, do not use this medication if you're breastfeeding. Do not use this medication if you are pregnant or trying to get pregnant. But that's really it. That one, there's not really that much with that one until you start taking OB in 3rd track. Oh, you are in 3rd track? Okay. Stephanie will kind of explain it more when it becomes a big subject with her class. But from what I remember, the pregnancy categories aren't that important compared to the other content, even in OB.
About the only time you might see the pregnancy categories come up in OB is going to be at your clinical site when you have to do a medication grid.
And then if you guys don't have any questions, of course, you are free to go. You do not need to stay. We don't have anything else to go over today. If you guys have any questions, you can reach out to us. I'll put my email in the chat.